Welcome to Chapter 3. We're going to talk about the Uniform Hospital Discharge Data Set. One thing to remember, you probably had this back in Health Records Management. So again, if you want a little more information on it, read through that material from that course. Okay, we're going to go through the disclaimer. So with the UHDDS, it's used for inpatient data. Okay, again, inpatient, not outpatient. Just a quick reminder, inpatient is anybody that's been in the hospital more than 24 hours, acute care, which is usually a hospital that patients stay at less than 30 days, short-term care and long-term care. And it's just a set of standards with definitions to provide consistent data for users. It is required for Medicare and Medicaid patients. And a lot of other health payers do require this too. So what's all on there? The basic thing is going to be principal diagnosis. Other diagnoses that have significance for the hospital episode, any procedures. And again, age, sex, insurance, who's going to pay, or is it yourself, and hospital identification. Okay, so originally developed for hospital reporting of inpatient data elements. So other different things that it can apply to is you can read through the list here. Okay, so let's start here by talking principal diagnosis. This is so important in coding. It's the condition established after study to be chiefly responsible for admission of the patient to the hospital. So the importance of accurate designation of the principal diagnosis is huge. It's significant cost comparison, analysis, utilization review, and third-party reimbursement. So when we're talking inpatient, it's solely based on that principal diagnosis. So again, when we say after study, okay, so let's say that I go into the emergency room with abdominal pain, and they run different tests on me. They run blood work. Let's say they did a CT scan. They did, X-ray. Okay, and again, they're thinking, well, it could be your gallbladder, it could be possibly appendicitis. So the blood work comes back and I have abnormal white cells. So they're thinking, you know what, she has an appendicitis. Okay, so again, what the principal diagnosis is after study is going to be appendicitis. It's not going to be abdominal pain. Okay, it's after study, what did they come up with that was wrong with me? Abdominal pain is a symptom of appendicitis, so I would not even code that. Okay, so here again, it's not the admitting diagnosis. It's found after workup, what I just talked about. It's listed first in the physician's diagnostic statement, but again, it's not always the case. That's why it's very important for a coder to always review the entire medical record. Okay, so again, inpatient always governs the selection of a principal diagnosis. It needs to be consistent, complete documentation in the medical records, very important. We'll get more into documentation as we go down the road. Observation, we could have a patient in observation. At that point, they could be discharged, or they possibly could end up admitting the patient. So again, you want to report the medical condition that led to the hospital admission. So admission following a post-operative observation, again, keep in mind, I always say to the students, what was the condition after study that brought them to the admission of the patient to the hospital for care? Okay, so again, you've got to go back to this rule. Same thing with outpatient surgery. So if a patient was in outpatient surgery, let's say they were in there for cataracts, following the guidelines should be selected. If the reason for the inpatient admission is a complication, then you would assign that complication. So let's just say that they were, this is a bad scenario, but having hemorrhaging. Okay, they had cataract surgery and had hemorrhaging from the one eye. The complication would be hemorrhaging. That's going to be now my principal diagnosis for that inpatient stay. Okay, admission encounters for rehab. Again, principal diagnosis, sequence the first code for the condition which the service is being performed. All right, so let's say we have 2 or more conditions. In the unusual situation, we have 2 or more diagnoses that equally meet the criteria for principal diagnosis. At this point, you know, either diagnosis can be sequenced first. I always like to tell my students in advanced coding, we're going to optimize. What code is going to bring the facility more money? And then we're going to get into MSDRGs. So once we start talking about that, if we put either of these codes first, which one is going to, again, bring more revenue in? And again, it's not fraudulent because they both equal the definition for principal diagnosis. When treatment is totally or primarily directed towards one condition, or when the one condition would have required an inpatient admission, the condition should be designated as your principal diagnosis. If you have comparable or contrasting conditions, both diagnoses should be coded as confirmed. Again, your principal diagnosis is according to the circumstance of admission. Was there diagnostic workup for that principal diagnosis? When no further determination can be made as to which diagnosis is more closely meets the criteria for principal diagnosis, then again, either diagnosis may be sequenced first. This does not apply to outpatient. Again, everything I'm talking about right now is inpatient. When you have an original treatment that wasn't carried out, okay, the criteria for designation of the principal diagnosis does not change. So let's just say that I went in and I was supposed to have a hysterectomy. While I was on the table, I went into cardiac arrest. Okay, they didn't do my hysterectomy. So let's just say that my diagnosis of endometriosis is what I was going to have my hysterectomy for. That is still going to be my principal diagnosis. Okay, so cardiac arrest or myocardial infarction, again, is going to be another diagnosis, but what were you admitted for? You were admitted for endometriosis. Other diagnoses are conditions that coexist at the time of admission. They develop. They have no impact on the patient care during the hospital stay. These are not reported, even when they are present. We have a lot of this with like the osteoporosis. If we're in for a heart condition, that osteoporosis isn't going to make a difference for the heart condition. Okay, so includes of other diagnoses. These are conditions that affect the episode of hospital and care. So any of these, clinical eval, therapeutic treatment, further eval by diagnostic studies, procedures, or consults, possibly extended length of hospital stay, and then increased nursing care or other monitoring. And there's no other really sequencing of the diagnosis in order. Even when this semester goes along, I'm always looking for that principal diagnosis first. Now, there is rules for sequencing, but not really of secondary diagnosis. Okay, previous condition stated as diagnosis. This is just going to be your history codes. Again, we'll talk about that when we hit our Z code section. So again, chronic conditions that are not the thrust of treatment, it's going to depend on if somebody has COPD. Okay, if it wasn't the thrust of the treatment and possibly not treated specifically, are reported because they are also required evaluation and monitoring. So somebody with COPD, okay, even again, you are going to report it because they have to evaluate that. Right? So anything that you have to do the severity of the condition, did they have to treat it? Is the doctor changing up the medications for it? Then again, that diagnosis probably needs to be reported. Okay, so here we talked about this, conditions that are integral part of the disease process. So let's go right down to the example. A patient is admitted with nausea and vomiting due to infectious gastroenteritis. Okay? Nausea and vomiting are common symptoms of infectious gastroenteritis. Therefore, we do not code them. Okay? Second example, a patient was seen in the physician office with urinary frequency and was diagnosed with BPH. Although urinary frequency is a symptom of BPH, both conditions are reported because there's an instructional note that tells you to do so. Okay, this is why it's really important. Once I look up my code in the alpha, I need to double check it in the tabular to look for extra characters and for notes telling me if I need to code more. Okay, so conditions that are not an integral part of the disease process. Example, we have a 5-year-old boy who was admitted with 104-degree fever with pneumonia. During the first 24 hours, he also experienced convulsions due to the high fever. So both the pneumonia and convulsions are reported because convulsions are not routinely associated with pneumonia. No code is assigned for the fever. However, because it's usually associated with pneumonia. If somebody has pneumonia, usually a fever runs with it. So again, if it's related to my diagnosis and if it's a sign or symptom, I don't code it. Abnormal findings. Just one thing I want to state on this real quickly is codes should never be assigned on the basis of an abnormal finding alone. Here's a perfect example. If I'm in lab and my hemoglobin's low, okay, and you have a coder who decides, well, they must be anemic, I'm going to assign the code anemia, okay? That's not necessarily, you don't know what happened. Maybe it's a female and they're menstruating, which could possibly drop their hemoglobin. So again, we don't know why that the doctor needs to state. Okay, this is one thing I need to do. Never go off, again, a diagnostic test or lab test. All right, admitting diagnosis is not an element on the UHDDS. Inpatient admitting diagnosis, this is usually what they're coming in for. Working diagnosis. Procedures, they require that all significant procedures be reported. We will get into procedure section coming up. Relationship of the UHDDS to outpatient. One thing with outpatient, we'll get into that too. This is, again, there's no more after study because if you're an outpatient, they probably didn't run a lot of tests. I'm not saying that they didn't, but a lot of times we can't come to a conclusion. So we'll go through some certain words with outpatient. And then ethical coding and reporting. Medicare reimbursement depends on the correct designation of a principal diagnosis. When we start talking about an MSDRG system, this is where we don't want to become fraudulent. We want to figure out what the principal diagnosis is, not the diagnosis we think that's going to bring in more revenue to the facility. Okay, so make sure, again, you read through the rest of the PowerPoint. I hit what I think that, you all need it, but I'm not saying read through the whole chapter, read through the PowerPoint. If you have any questions, please let me know, send me an email. That would be great.